Maybe let's go. Okay, let's get things started. Good morning, everyone. It's a pleasure to have everybody here. We're going to start one more Friday session here. This one is our pituitary session. So we have here Dr. Sampson, we got Dr. Pless, I see Dr. Edgar, and I saw Dr. Hammock for a second as well. I see Dr. Hammock here. And I see Amanda McKenna, endocrinology fellow too. So we got the team ready to go. Who's going to go first today, Joe?
It's Gaetano.
Okay, Gaetano. So let's get things started.
Hey, JP, I'm having some issues. Oh, you can hear me clearly? Perfect.
Yes, I do.
There is some lag on my end whenever I hear you talk. I don't know, probably it's just me. Okay, let me share my screen. All right, I hope you can see my screen and hear me fine.
Yeah. We see it well, Gaetano.
Perfect. I may not really understand everything that you say, but yeah. Hopefully we'll get better the connection. So today is our pituitary session, and I will be presenting a case done by Dr. Shaichana, Dr. Almeida from the neurosurgery team, as well as Dr. Dr. Donaldson in ENT, and Dr. Samsung in endocrinology, and Dr. Edgar Elft with the pathology slides. And it will be presented by Dr. Amanda McKenna, the endocrinology fellow, and myself. So this is a 34-year-old male that noticed at the beginning some vision changes. His vision progressively started getting worse, and he saw first an optometrist and then even saw a retinal specialist. When he went to the ophthalmology, they found some abnormality on the visual fields, some visual fields deficits. I looked in the chart. I was not really able to find visual fields from the outside institution, and they were not repeated here, so I cannot really go too much in depth about that. So after they found this abnormality in his visual fields, he had an orbital CT and brain MRI at an outside facility that showed, as we'll see later, a very large pituitary lesion impacting the chiasm. I saw also endocrinology outside, and they did some labs that revealed a prolactin 6,215. So he was started on cabergoline 0.25 milligrams twice per week. And at the 3 months follow-up, his prolactin decreased to 2,137. And we'll see also some more labs later on, and endocrinology will expand on that. So at this point, we have a very young gentleman, 34-year-old. Everything started with some visual complaints. At a workup, they revealed fairly elevated prolactin. Started on cabergoline, and you can still see at 3 months, very elevated. So during the first year, the tumor did shrink. They got repeat imaging, and we'll see them later. But the visual fields also improved, but the prolactin never normalized. And it was in a fairly high dosage. And endocrinology, if he wants to expand on this, he was on cabergoline 4 tabs 4 times per week. So 8 milligrams in total per week. And also bromocriptine now, 2.5 milligrams daily. So this is a giant prolactinoma that has been partially responding to the cabergoline, given the response on the imaging, on the MRI, but considered resistant given the fact that the prolactin did not normalize. Dr. McKenna, if you're on the line and want to expand further on this.
No, I think you got it all. I mean, the fact that he was on such high doses, both the bromocriptine and the cabergoline, and still did not normalize, I think speaks to the resistance to the prolactinoma. Dr. Sampson?
Yeah, I mean, I think when you start getting upwards of more than 0.5 per day or a tablet per day, which is 3.5 milligrams per week, you're not going to win this battle. And the addition of bromocriptine is a bit strange. It has less affinity for the very same receptor. So we discussed at the meeting that he could, or at our first meeting, that he could stop the bromocriptine, because I think it was more like a little drop in the bucket compared to the amount of cabergoline he was on. But even so, This is the type of dosing that you start to get concerned about impact on valves because of valve thickening and other impacts from cabergoline that now could have other ramifications for his health. So that's why this story unfolds this way.
Just a quick question. So we have no idea why they hit the bromocriptine, and that's a tiny bromocriptine dose for those of us who are old enough to have used it regularly. But I've never seen that.
Yeah, it's a Hail Mary. And I think given the long half-life of cabergoline, which even stays within the tumor for a good month, even if you stop it, and the short half-life of bromocriptine, I think they were just trying anything. There's one paper from Mark Molich where he used cabergoline used bromocriptine in a cabergoline resistant tumor, and he published that, but that's really not not the norm usually.
Gotcha.
Thank you, Dr. Sampson and Dr. Burnett. So past medical history was only remarkable for Hashimoto thyroiditis, no past surgical history, and also no relevant family or social history. When he was seen here in exam, he was grossly intact. His vision had improved. He just had some visual field deficit on the right eye. I didn't really see the extent of the quadrant anopia versus hemianopia, so I cannot really comment on that. And as I said, we don't have a visual field to show. And these are his labs on presentation. Dr. McKenna, if you want to comment on that.
Sure. Can you hear me? Okay.
Yes,
sorry,
there was an echo.
Okay, sound like there was an echo initially. I'm sorry about that. So as you can see, the initial prolactin that I included was 353. That was on the high doses of the cabergoline and the bromocriptine. In order to prepare for surgery, we actually took him off of both of those medications, and the 790 was his preoperative prolactin. And then not surprisingly, with the elevated prolactin, his testosterone was on the lower end.
I'll just make one quick comment. You don't have to go backwards. So you may look at the estrogen and go, why are you doing an estrogen in a 34-year-old man? So we know that sometimes testosterone gets converted to estrogen, and in cases of resistance of prolactinomas, if the estrogen is high, that can actually drive that resistance. So you want to make sure that's not what's happening. And there are also some reports of using aromatase inhibitors to help improve the responsiveness of these tumors. We're not big fans of that because it decreases bone density, but that can be a way to work on the medical therapy. But when we have great surgeons here, I think we move forward with looking at taking this out.
All right, here you can see the original MRI from March 2021 on the left, and then we have the follow-up scan on the right side. So this is a coronal view, and you can see a fairly large, I think it's a 3.3, measure on 3.3 centimeters in maximum diameter there. And you can see cellular, supracellular extending all the way and compressing the chiasm upwards. And you can see here also the relationship with the carotid and cavernous sinus, no clear invasion that I can tell from this scan. And then here you can see the repeat scan after it was on the bromocriptine and cabergoline, that the tumor had shrunk a bit, especially the supracellular component, but still fairly large. I think they measured 2.8 centimeter in maximum diameter. I don't know if you have somebody from radiology on the line, or
Gaetano,
comment.
Before you go on, just a quick question.
And I have a sagittal view on the next slides.
Okay. Gaetano, quick question. Why was this not seen by neuro-ophthalmology? Gaetano, do you know why this patient was not seen by neuro-ophthalmology?
That is correct, sir. It was not seen by neuro-ophthalmology.
Why?
It's a good question, Dr. Platt. Plus, I saw him in August.
I was not involved at that stage in his care. I don't know.
I'm sorry, Dr. Sampson, were you commenting on something? I'm sorry, I overheard Gaetano when you're mentioning something.
Yeah, so Dr. Pless, I saw him in August and had immediately had him seen by neurosurgery. So I think, both of our teams definitely should have sent him. He did have an outside neuro-ophthalmology appointment, which may be why. But yes, I agree with you. Should have been in your office.
Yeah, if I may add just to that comment, which certainly so is an important one. When I had a chance, I met this patient during the, just pre-op evaluation and so, but additional to the decreasing size of the tumor, of course, so a partial decrease in the size of the tumor. The patient mentions that it's interesting the way that he reports how he found out about this tumor. He was playing kind of like just, I forgot the name of it, with his father in golf as well. And then his father would always be able to see the ball well, and he wouldn't. He would kind of like miss that. And then when he, started, then he was diagnosed, and then he started taking the medication. His vision had, a pretty significant subjective improvement, despite that this just had a partial, decrease in size as well. Maybe go ahead, Gaetan.
This is Vishal Patel from Rayod. Just before you advance,
sure,
sorry,
sure.
just a couple of things here on the. It's probably easier to see on the April study on that slice if you don't move it here. If you see that very hyperintense linear thing along the left side of the tumor, that's actually the infundibulum that's stretched over there. If you were able to scroll back and forth, it's easier to connect there. It's coming from the right above the top aspect of the tumor where the infundibulum would originate and then stretch along the left side there. So it's a little bit easier to see if you had the pre-contrast T1 to help you find the pituitary bright spot and identify the pituitary, although in this case, we're kind of lucky and the enhancement of the tumor is a little bit different from the native gland, but that's not guaranteed. So I'm looking at the pre here on my screen, and there's a couple of areas of hemorrhage that show up on the pre-contrast as well. So. And then I think you said you have a sagittal if you want to advance.
Yes, sir. Thank you. Yeah, as you said, we can see the infundibulum and the pituitary push to the left side. And also, I don't know if you can comment on the changes that are seen. I think the outside radiological comments on some changes on the post-scan, even the fact that it was on cabergoline as well as the bromocriptine, some differences in the enhancement.
Yeah, there's some heterogeneity in the enhancement initially in March already, right? In the superior aspect, there's some cystic or non-enhancing components, but certainly the enhancement appears even more heterogeneous 1 month later. And there you are there on the very mid-sagittal section. You see a little focus of non-enhancement in the pars intermedia right there on that cut, which could be some fluid trapped in the Rathke's cleft, or maybe a little bit of hemorrhage on the T2 that I'm looking at here. It's very dark, so potentially a little finger of the tumor that's hemorrhagic extending down there. But yeah, clearly here it's a little bit easier to see the decrease in size.
Thank you, sir. Yes, you can see mainly the supracellular component significantly decrease, and you can still see the normal pituitary over here. And the patient did have another scan in May of this year before the surgery, and per report, there were no changes to the size of this lesion.
So this is the most recent scan that we have.
It's also ENT after seeing, endocrinology and neurosurgery.
Gaetano, can you hear me?
Pre-op CT of the sinus, and you can see that there is a septal deviation towards the right side. I have a sagittal as well. You can see a well-aerated sphenoid sinus, and it's been expanded by this lesion. Let me go to the next one, but there is no evidence of erosion.
Gaetano, can you hear us?
I see JP has his hand up. Let me unmute this computer.
I think you can't hear us, right?
So I cannot hear you from my computer, JP. I need to unmute the other one and hear you from the other one.
Yeah, it's just because we were trying to comment, like that MRI that you have there.
Go ahead.
From 2022 is the last MRI that you have available for this case?
Correct. The last MRI available in the system is that one there. The one from May.
Okay. Okay, so
there
finish.
was a report in the system of an MRI from May of this year, but the last
Okay.
MRI that I was able to see on Q-reads is
Okay,
from
so
April.
just finish describing the CT scan. And then let's go back to the MRI so I can show you a couple of things, please.
Yes. So we saw the coronal here on the sagittal. You can see again the expansion of the cella, but no evidence of erosion.
Good. Let's go back to the MRI. So in this MRI that you see there from April 22, first of all, a fairly interesting tumor because the prolactin decreased, the size of the tumor decreased, but as Dr. Sands, Dr. Bennett described, this is still a fairly complex tumor that has an interesting relationship with the sella. So the sella with the pituitary gland, I'm sorry. So the pituitary gland, you see that in this sagittal scan, it's just that it's here in the bottom. And then everything else is the tumor. Everything else, the tumor has this supracellular component. So basically, none of this tumor is in the cell itself. Everything is in a supracellular space. So occupying cisterns in this, namely the chiasmatic cistern in this space. And it has a component that does not invade the third ventricle. You see that this is the floor of the third ventricle here and lamina terminalis. So it respects that boundary. It's located in respect just below the acon complex on the top and has this inferior extension towards the retrocellar. So this is the dorsal cella here, which is pretty short in this tumor. In this patient. And expands behind the cella in the area that we call retrocellar space that in fact it's just the interpeduncular cistern. And then you see that the tumor has this bulging inferiorly here that if you go to 2021, it would have the same. That is a limit that often is caused by the presence of the Lilliquist membrane that kind of holds those tumors despite not kind of like allowing too much inferior growth. So in this case, show us a coronal, Gaetano, please. In this case, then you have the supracellular space that is clearly visible there. And then you have a component of the tumor that goes behind the cell, so retrocellular. And then you can see here that the pituitary gland is mostly to the left. And then here you have the pituitary stalk that is also to the left. And you're going to see that this is paramount in this case because since we need to work behind the pituitary gland, and this is a young patient with normal pituitary function, but the hyperprolactinemia, and therefore secondary hypogonadism, we definitely want to preserve the pituitary function to the best of our abilities. So looking at the anatomy of this case, what we planned therefore was an expanded endoscopic approach for the anterior fossa, namely the supracellular region, additional to a pituitary transposition using what we call a transcavernous approach with mobilization of the gland with the medial wall of the cavernous sinus, and then resection of the tumor in the retrocellular space. The goal, of course, maximum safe resection and hormonal preservation. With the caveat to remember that this is a prolactinoma, and definitely so, if any area is considered deemed too risky, we can, and the significant debulking is achieved, we don't have to, expose this patient to too much risk in our maneuver. So maybe, Gaetano, let's go ahead and see what you have.
Thank you, JP. Okay. So as JP said, we have a patient with a very young pituitary macroadenoma. It's been resistant to the medical treatment, and we heard about the side effects from Dr. Samson as well. So recommendation was done for endoscopic endonasal transsphenoidal pituitary tumor resection. Given the very large size of the tumor, the persistent mass effect on the chiasm, and the failure of the medical therapy. Here we have the surgical video. And I want to thank JP for editing the neurosurgery part. It's beautiful. I'll skip through very quickly over the ENT, nothing special. Here you can see the lateralization of the inferior turbinate. Here doing the cuts on the mucosa to elevate then the nasoseptal flap. You can see here the vertical cut. And this patient had a septal deviation, so a septoplasty was performed as well. Dr. Donaldson, if you're on the line, feel free to comment and interrupt at any time. Here you can see her working against the septum, elevating the mucosa and performing the septotomy. He had a bone spur, which was removed as well. It just fly through. Here you can see the sphenoid os, which is working with the Carrison to expand the opening there, removing the mucosa. And then with the micro debrider, drilling the septation in the posterior sphenoid, expanding access here, and you can see the intestinal septation being drilled out at that point, and removing. Here's the nasoseptal flap being pushed to the side.
Okay.
And here you can see this is
Gaetan, do
JP's
you hear me?
part. Go ahead, sir. Yeah.
So basically, this is the transtuberculum extension there. So pause the video for a second, Gaetan. Perfect. Yeah, perfect. Right there is good. So what you guys see here, this is the optic canal. This here is the clinoid segment of the carotid, and the carotid will be curving just in this direction here towards the paraclival. This here, therefore, is the left optic canal that you can see just because of the angle. Up here would be the plenum. And then communicating from roof of the optic canal to roof of the optic canal. I'm sorry, not exactly straightforward line here. You have a line that is the limbo, and that's what's going to be the limit between your suprachiasmatic and infrachiasmatic space. In this case, we deem that it would not be necessary to really extend too much in the plenum. That's basically in the sagittal cut. And then you see here that you can play the video a bit, and so our approach would be deemed around here, but we're going to expand to the right side because we need to have exposure to the cavernous sinus on the right. So you see this line that you see right here in the middle, that's not the limbus, that's the superior intercavernous sinus. And here, using the diamond bore, I'm just drilling so can expose the carotid on the right side. And then here to expose the most medial part of the optic canal on the right side. After that's done, using the double ball probe to mobilize that thin bone, so blue line, then dissecting the bone out. And then we can start to see the glimpses of the clinoid ICA, and then it's curving like this here. But then I have to drill this inferior part so we can get some access to the paraclival. And more importantly, so to expose this anterior wall of the cavernous sinus and to find a safe entry zone into the cavernous sinus, using the Doppler just to map that space. And then we go back to the midline. So it's always the same thing, at least to me, with the suprasellar approach. So opening the pituitary gland, and you can see this is completely normal gland underneath the dura, just exposing that space a bit more. And then we work just below the superior intercavernous sinus. After that's done, you're going to see a second cut that is going to be done right here to open the dura of the suprasellar space directly. And then you see layer by layer. And then after that, you can separate the dura from the tumor and ligate the superior intercavernous sinus. Once that is ligated and transected, basically you open the window between the cella where the pituitary gland lies and the suprasellar corridor. Then you have to, expand that approach to visualize the tumor in its entirety. And then it feels okay, it's going to be ready to start. The answer is no. We need to get the cavernous sinus on the right side. So that's the second corridor in this case. And then you see here that mapping the carotid, working the medial to the carotid and lateral to the gland, open a space, get the McAlvin knife as usual. Then with that, we open a corridor that will allow us then to create hemostasis inside the cavernous sinus. And then we continue opening. If you can pause the video, Gaetano, for a quick second. So you see that now the carotid is here, the normal gland is here, And here we opening the cavernous sinus. So this is all cavernous sinus here, okay? And then here, this is where the diaphragm is lying in relationship with the superior intercavernous sinus. And there is going to be a communication between the diaphragm and the distal dural ring. And that is the separation between the clinoidal space and the suprasellar space. So it's the separation between the space where you have CSF and the space where you're not going to have CSF. So you're going to see that as we open that distal dural ring here, we're going to be getting the cavernous sinus and that the suprasellar space communicated, and everything is going to be freed, and they're going to allow us to mobilize the carotid even more because the carotid is being held in place by those dural ligaments. Go ahead, Gaetano. So you see here the residual part of the distal dural ring attaching to the diaphragm. And then once we transect that, we're going to have that window open to be able to start mobilizing. What you see here is still connecting the gland to the carotid. So you see here, this is the horizontal segment of the carotid, are some of the ligaments, namely the inferior parasellar, and then up here, this big guy is called the carotid clinoidal ligament that I'm transecting here at this moment. And then, as I said, as you go towards the distal dural ring, you start to see CSF. And then that's communicating the intradural space with the clinoidal space, which is an interdural connection. In this area, then you just mobilize the gland, with the medial wall with the gland. And then you're going to see that I'm using some of the bipolar just to facilitate that work. But in the most posterior part, as I cut, I'm going to cut a bit early, and then you got a bit of a bleeding from the inferior hypophyseal artery. That's fine. You just work with your bipolar. You see that I was transecting, I was not dissecting, so that's safer. And then you get hemostasis. And then you mobilize the gland, once again, from lateral to medial. And then I decide to drill a bit more just to facilitate that exposure, because I need to have access to this, which is the posterior clinoid. With that being done, we transect the less residual attachments between the anterior wall and the bottom of the cella, the floor of the cella. And then we continue mobilizing the gland. Why am I mobilizing the gland like that? Because we want to, first of all, achieve complete hemostasis in the bottom of the cell in the inferior hypophyseal artery region, and be able to rotate the gland from lateral to medial to be able to expose then this area that you see now, which is the dorsal cella. So we can work around that area to remove that retrocellular component of the tumor. And now that the two corridors have been created, this is the tumor itself. You see that it's a very fibrous tumor. There is nothing soft about this tumor. And then transecting the capsule, opening the capsule of the tumor. And then we're going to proceed with some of the tumor resection in this corridor. Maybe Gaetano can, speed up just a touch. No, you can, move forward just a bit. Yeah, okay, stop there. And then you see we debulked some of the tumor in the top. And now what we're doing here, going to the left to find the pituitary stalk. And this is the stalk right here. Hope you guys can see it right here. And gland and stalk. So what we have to do, we got to preserve the stalk. So we got to continue dissecting and mobilizing the tumor away. So now that we have a plane between the stalk and the tumor, we need to remember that the stalk is going to function only if you preserve the anatomy of the stalk and the vascularization that supplies the stalk. So if you preserve both superior hypophyseals, that's better. But to have some chance of function, you got to preserve at least one of the sides for sure. So we become more aggressive on the right side rather than the left side, and we don't dissect the arachnoid away on the left side initially to avoid that. You see that we're using this instrument that is a microshaver, and this is called the nucleomyriad, and then it allows us to debulk some of the tumor. Since we didn't see any descent and the tumor is very fibrous, we decided to expand even more superiorly. And then you can see some of the top of the capsule and its relationship. Stop the video for a moment. With this vessel here. This vessel here in the front, it's not just a vessel supplying the tumor. That's a superior hypophyseal artery branch, likely going to the stalk all the way on the top of the tumor on the other side, but also going to the optic chiasm. So that one we definitely didn't want to sacrifice because it could have led to visual changes. And Therefore, I had to work around that vessel to try to maximize tumor resection. So keep going, Gaetano. So you see that that vessel is or wall is our limit. I was not inclined to kind of try to pursue, beyond that vessel. And here, continuing debulking the tumor and debulking the tumor. And you see that here I'm trying to work between the vessel, but there is a fibrous component that is kind of intertwined between those. So I transect and I debulk that to the best of my ability and we try to leave whatever kind of like capsule or residual is on top of that vessel in order to minimize potential visual changes. Here, what you see, stop the video, please. Good. You see, so this is the capsule of the tumor. And what you're going to see in a second, this big vessel here, of course, is the supraclinoidal ICA, okay? And as Gaetano plays the video, you're going to see that as we inspect the capsule, we just had too many perforator. You see there, like the branches that we're also going backwards to supply on the contralateral side, and decided not to chase an extracapsular on that area to minimize chances of new deficits. So once the supracellular debulking has been completed, now it's time to work in the retrocellular space. So finishing here, we see that we are transecting attachments of the gland to the dura in the dorsum of the cella. And that's going to allow us to basically not only mobilize from lateral to medial, but to rotate the gland. And such rotation allows us then to get space to debulk the retrocellular component now. And after that is significantly debulked, we're going to be able then to get to the posterior part of the tumor in the retrocellular component. And you're going to see that we're going to reach the interpeduncular system. So here's just opening the posterior capsule of the tumor, the posterior wall of the capsule of the tumor. And then as that is debulked, you're going to see the basilar trunk and its branches. So here we're just inspecting to make sure that there was no perforators attached to the back wall of the tumor. And you see that pretty well here. Once that has been achieved, the tumor had been debulked. It's time then to inspect and to go once again towards this stalk. So here you see, if you stop the video for a second. No. Okay, good. Yep. There, perfect. So this is the basilar trunk. This is the PCA. This is the SCA on the right side. And then you're going to see the same thing on the left as we move on with the casing. Go ahead. So stop the video right there, just a second. Yeah. So you see here, this is the stalk. I'm just going to illustrate because you know how much you can see that well. And then with the dissector, now that the tumor is debulked, then we're going to mobilize that tumor away from the stalk. And that's, you're going to see that now it's going to be much easier. And then once that is mobilized, we're going to use a scissor. You can play the video, Gaetano. We're going to use a micro scissor to cut the capsule of the tumor and mobilize that away from the stalk. Once again, mobilizing it from the right side of the gland towards the stalk towards the tumor, and not being aggressive with the left side, because to preserve the function of this guy is an important goal for us today. So you see coagulation and transection, because certainly, so we got some branches of the superior hypophyseal that were supplying this stalk on the right side. And as we transect that, we have to go towards the roof of the capsule of the tumor to be able to fully separate that tumor from the stalk. And that's what we're doing right there. You see, using angle scissors, you just dissect and cut, and then you can start kind of like to rotate that component of the tumor. So you see that this is, just applying microsurgical technique in endoscopic surgery, but it's exactly the same thing. And you're going to see that once this component is mobilized, what we're going to have to do now is to rotate this tumor and get it out. It is, conceivable. It is appropriate to be concerned with branches from the basilar, but here you have to use the cognizance that, first of all, you see that I'm just dissecting the tumor attachment to the gland, which is interesting. It had like a clearly separation, and the gland was not small or anything, which is often what we see. See that the tumor is very, purple in color or so. I believe that's just the effect of the medication. And then you're going to see that as we mobilize that, we mobilize from inferior to superior in a very progressive type of fashion, very slowly and gentle, using the liliquist membrane to protect us from many perforatory branches that will be attached to the bottom part of the tumor. Once that is complete, you see that I'm just mobilizing the tumor attachments that are close to the oculomotor on the right side that was attaching to the lateral attachments of the liliquist membrane. And then we can mobilize that tumor away. You're going to see that tumor is going to start basically rolling out of the surgical field. And there you go, just with this suction, you see that that tumor is now mobilized, and we can, slowly bring it out of the field. And then this is part number 1. And then you're going to see a lot of it just coming out there. And then you see here, can you stop the video there just so I show that anatomy? So basilar trunk, you got PCA on the left, SCA, third nerve on the left, you got the SCA, PCA on the right, and oculomotor on the right. And then of course here, this is the basilar tip. And here you got, this is the entire view of the front of the interpeduncular cistern. And therefore demonstrating the complete resection of this retrocellular component of the tumor. Play the video, Gaetano. And there you see some mobilization. You see, I was just inspecting to see what was safe or not to mobilize from the area in the capsule. And we felt deemed that there was only very small component of capsule on the left side. In our point of view, we decided to leave it there, especially so because of the stalk. Certainly we could remove it, but they don't want to devascularize the stalk in a prolactinoma that the goals apparently had been achieved. And you see the reconstruction by Dr. Donaldson, a complex one. So 2 layers of drusen, 1 inside the gland, behind the gland, 1 on top. So inlay and onlay, followed then by vascularized nasoseptal flap. That certainly so is very important in such a case where you have a high flow CSF leak due to opening of the chiasmatic and interpeduncular cistern. And then the flap, which is indeed the most important layer, being placed in well positioned. Maybe let's go to the post-op results, Gaetano, just so we can move on to the next case as well.
Yes, JP, thank you.
Thanks that it took a bit longer to describe this case, but very complex approach with many steps.
So we have some pathology slides from Dr. Edgar. I think you're on the line, sir, if you want to comment.
Yeah, I'll be brief. So this is a pituitary adenoma. These are monotonous cells with clumped chromatin and a modest amount of pink to amphiphilic cytoplasm. I go to the next one. And you see drug effect here. All these small cells with the very minimal cytoplasm running through the center and the upper right. Yeah, all that. So that's drug effect, either bromocryptine or cabergoline. You can see some cells at the bottom center that retain their cytoplasm. So typically the drug effect is patchy. Go to the next one. Prolactin, immunostain positive, as expected, prolactinoma. And that may be the last one. Or, oh yeah, here we go, PIT1. So growth hormone, TSH, and prolactin governed by this transcription factor. So I may have a MIB, I'm not sure, but yeah, there's the MIB. It was not elevated. So very, very good prolactinoma with evidence of drug effect. Also see the fibrosis here. You can't, in between these nests and trabeculae, yeah, that stuff there. Much more fibrosis, and the tumor came out in one big nodule, whereas we usually get these little niblets of tumor. That's also fibrosis and drug effect.
You're muted, Gaetano.
Oh, thank you, Diogo. I was saying, as expected, final pathology was a pituitary adenoma, prolactinoma. So here's the post-op scan. On the left, we have the pre-op, just for reference. And here you can see pituitary gland preserved, very nice resection, just that superior portion on the left there that JP mentioned, given those perforated being around that area. But beautiful resection there. And there was some comment about radiology, about some diffuse meningeal enhancement. I don't know if Dr. Patel wants
Yeah,
to comment on
the
this.
sulci are all kind of lit up post-op, but that happens sometimes. Usually a chemical meningitis. I think this patient was asymptomatic, but yeah, this is a good example, I think, on this post-op case of why that pre-contrast T1 is useful, because even in this same tumor, you can see, depending on exact timing, the native gland is very difficult to distinguish from residual tumor. So it's nice that we have that pre-op. We can trace that infundibulum down because the shape of the residual gland due to manipulation has changed as well. So it's difficult to identify morphologically or distinguish from residual tumor without the pre-contrast and the pre-op imaging.
And this is again sagittal view, showing the small area of residual, the gland preserved there, and really beautiful resection. And you can see the proximity there to the basilar, all the structures that JP mentioned on the surgical video. Very challenging case. JP makes it sound easy, but it's definitely not. Postoperatively, the patient did very well. He spent one night in the neuro ICU and went home on post-op day 2. There were no signs of CSF leak, no DI breakthroughs. His cortisol was greater than 15. He didn't need any hydrocortisone. As I mentioned, the MRI, there was the note of some leptomeningeal enhancement, possible aseptic meningitis. He did very well. We just kept him for antibiotics, left him for 2 weeks per ENT, and his post-op prolactin was 129. And we have some more labs. If Dr. McKenna wants to comment on this.
Yeah, so as you mentioned, the prolactin did drop to 129, and on post-op day 8, it's dropped even further to 51, which, given the size and the extent of the elevation previously up to 6,000, would be considered a good response. Just to note as well, on the post-op day 8 labs, FSH and LH were low, which could be indicative of an evolving secondary hypogonadism. However, that will need to be retested further out from the surgery. And then just to note, he did have some mildly low sodium. It sounds like, well, we know from days 4 to 8, our policy is to do the fluid restriction because that's the second phase of the triphasic response, can be inappropriate or SI-ADH. And after talking to the patient, he actually had ended his fluid restriction a little bit early. So not surprisingly, his sodium was a little bit low. So we'll be monitoring that closely.
I think
Dr.
that
Sampson?
the second factor is that he does have a prescription for acetazolamide, and we have to remember that that causes loss of sodium in the urine and contributes to hyponatremia as well. So we can battle that with fluid restriction, but if they're on Diamox, it can make it a little more challenging.
Yeah, I agree. Like Dr. Sampson and I have talked about this is like it's something that we can discuss. I think there is opportunity to manage some of those patients without Diamox. I think that has been, proven successful as well. But it's something that it requires some discussion between us and the team. But as Gaetano said, it's a lot of work in this case. Like even all the steps that we have to follow to get, technically speaking, the surgery are very complex in terms of preparation and application. But thankfully, so we have the team, we have the equipment and the experience here, and we'll be able to do those cases. It's fairly interesting because Dr. Sampson and Dr. Edgar, like when I look at that image, I was very, kind of like, this is a very funny looking pituitary tumor, and I was kind of like, I don't know, is this going to be a mixed one or something like that? I don't know. I was just surprised to see that type of behavior.
I think it's treatment effect, fibrosis, and the cells shrink. There's a variety of theories on what happens exactly to these cells. Some studies suggest they lose their granules. Some of the cells become necrotic. They undergo apoptosis and para-apoptosis, but a lot of things happen, and fibrosis as well. So, same risk as the fibrosis to the cardiac valves.
Question for Dr. Edgar. You had mentioned there's heterogeny when you look at the tissue and that loss of cytoplasm, and then now with others. I wonder if you did micro dissection of the two things, if the molecular pattern of those cells would be different between the two populations that you're seeing. And then this person had resistance, and maybe the ones that are retaining their cytoplasm and stuff are the resistant cells. I mean, it's just from a maybe clinically it's not, but so relevant of a decision-making thing, but just from the pathophysiology of this issue, I just throw that out as an idea.
It's a great idea. We don't do that kind of study, but I would think gene expression profiling on those two areas that I showed would probably be quite different, because there were a lot of areas, as there typically are. There's some that show retained cytoplasm, big cells, and those are just not for some reason getting the drug effect, presumably because they express some proteins that make them resistant.
Very good. I think that, especially considering the time, maybe Diogo,